Now, when I heard that Johns Hopkins Tech Transfer was considering starting a health tech accelerator, I have to admit I was a bit skeptical. Much as I love my alma mater, acceleration and tech transfer are not words historically you hear used together. But I was surprised to learn, and many of you now know, tech transfer at Hopkins is under new management. And with Christy at the helm, it's management driven by experience on Wall Street, by a different pace of events, experience driven starting and running biotech startups. And we can expect amazing things to come out of tech transfer in the university in the years to come. But the first company I'm going to introduce to you is really the best example of what you can expect to be coming in the next year. So without further ado, I'm going to introduce Emocha. Please welcome them.
Hi, I'm Sebastian, and we're Emocha, a mobile health platform for remote patient management. We provide researchers and clinicians with tools to facilitate mobile data capture, education, and communication. Dreamit began 14 weeks ago, and since then, we've signed 3 pilots and 7 deals with committed revenue of more than $600,000. Now, these 10 applications are in very diverse medical fields, and they're addressing really diverse issues as well, but they have one thing in common, and that's the need to manage patients remotely. These applications are in reconstructive surgery, post-surgical discharge, smoking cessation, tuberculosis, multi-drug resistant TB, teen partner violence, HIV, weight management, and medication adherence. Now, each of these applications sits on top of our mobile health platform, and each of them is fighting with one of 2 issues: linkage to care or adherence. Emocha was invented in 2008 by the Center for Clinical Global Health Education. That's right here at Hopkins. And what was initially intended as a research and education tool is now a dynamic platform for innovation in mobile. After the CCGHE launched 15 applications in 10 different countries, we licensed Emocha to repurpose it for commercial use. That was back in September of last year. So, all of the features that you see here are the strength of Emocha. It's a broad set of features across our core functionalities. And all the features that you see here are used in our first use case that we're going to present to you today. South Africa is going to be using Emocha to manage multi-drug resistant tuberculosis. Linkage to care is a huge problem in South Africa. Every year, 16,000 patients are diagnosed positive with the disease, but half of them are lost to follow. They don't make it to care, and the consequences for them are, in many cases, fatal. We're going to interface with the National Health Laboratory Service in order to capture positive diagnoses in real time. Then we're going to send out notifications and alerts to multi-drug resistant TB clinics, primary care clinics, the patient themselves, and tracing teams in order to link the patient to care within 5 days of a diagnosis. Now, we're going to roll out Emocha with the government of South Africa to more than 10,000 healthcare workers and 2,500 primary care clinics. I was in South Africa about a month ago. This is a big project and a big responsibility for us. Now, our next use case is adherence. Medication adherence is a complicated topic. There's a lot of behavioral issues there as well, but there is a solution that works for medication adherence, and that's DOT, or directly observed therapy. Now, that's when a healthcare worker actually watches a patient take their medication in person every single day. Now, that's impractical. It's burdensome for the patient. It's too costly for our system, but Emocha has a solution. We're piloting a medication adherence app that uses video capture as a proxy for DOT. So the application records the patient taking their medication, captures symptoms, and then securely submits it to the Emocha web interface where a clinician reviews it and assesses it. Once we're done piloting this, we're going to roll it out to 3 customers. The city of Sydney, Australia, the epicenter of healthcare in the world, the state of Maryland, and the National Institute of Health, which is just a few miles away from Baltimore, Maryland. So our third use case is actually a little bit different. While we're really proud about the global health and public health work that we're doing, Emocha is perfectly suited to be used here in the United States to solve big problems in healthcare here. So hospitals are wrestling with a problem. They're being reimbursed more frequently with one bundled or capitated payment for an episode of care. An episode of care lasts, however, not just from, for example, a surgery, but 30 to 90 days afterwards. So essentially, the hospital's on the hook for avoidable costs that occur post-discharge. In 2011, more than $25 billion were wasted on avoidable complications and readmissions post-discharge. So hospitals have an incentive now, not only to avoid those costs, but also to provide better care and to work on follow-up. And that's where Emocha comes in. We're piloting Emocha with the Johns Hopkins Department of Surgery in order to capture patient data from the moment they leave the hospital. From there, we're going to give them coaching and educational materials in video format to keep them on their care plan. And notifications are going to maximize adherence. All the data is going to be submitted to the Emocha web interface for the clinician to review. So these are 3 use cases for Emocha where we're helping solve linkage to care, adherence, and post-discharge remote patient management. Our strategy going forward is twofold. On the international front, we're going to continue to cultivate our referral network. Emocha has a really strong reputation in public health, and we're going to sign 3 to 5 strategic, high-impact projects in the next 12 months. Domestically, we really see potential for enterprise version of Emocha for post-discharge remote patient management. We'll approach the discharge management and case management departments of hospitals in the United States, large medical centers, especially the ones that have already moved to a capitated model of reimbursement. The team that got us here this far is trained in law, accounting, healthcare business administration, user interface design, and computer science. So we covered the commercial basis with these teams. And we're really privileged to have a stellar advisory board comprised of experts in mobile health, global health, infectious disease, operations, and informatics. I'm standing here today thanks to these people, many of whom are in the room today. So, going forward, we have excellent people. We have traction in mobile health. And we're faced with a problem that we're really glad to have. And that problem is that there's demand for our product, and we need to keep pace with that demand. So in order to do that, we're going to need investment. We can sell 20 to 30 enterprise Emocha applications for post-discharge remote patient monitoring in the next 18 months. But to do that, we're going to have to do 2 things. We're going to have to expand our platform to be able to handle significantly more business. And the second thing we'll have to do is develop our technical and operations teams to be able to roll out Emocha and then support the product professionally. So, in conclusion, we're opening a round of investment this summer, early this summer, in order to expand our infrastructure. The people are there, the market's there, the product's there. So now we just need to expand our infrastructure. The pace of innovation here at Johns Hopkins is really speeding up. We've done our homework. We've put all the pieces in place. We're at the right place at the right time. So I'd like to thank Johns Hopkins. I'd like to thank Dreamit, BioHealth Innovation, our sponsors, and our excellent counsel at DLA Piper for all their support. Thank you very much.